Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series, I will be speaking with Manchester cancer researchers about their innovations, discoveries, and projects that are changing the landscape of early detection. In this episode, we speak to Professor Phil Crosbie and Professor Emma Crosbie about their research in the early detection of lung and womb cancer and their work on community screening and addressing health inequalities. With cancer incidence rising, especially amongst the most socially and economically disadvantaged communities, the need for early detection interventions has never been more important. Phil and Emma Crosbie, hello.
Hello.
Thank you for joining me. How are you doing today?
Very well.
Yeah,
Very
really
well.
good. Thank you for asking us.
Oh, I'm great. Thanks for asking me. Oh, it's so great to have you both on. And I mean, I'd like to get into the nitty gritty, but I mean, you're both a cancer research power couple. This is the term that we've coined, cancer research power couple. I love it. Phil's shaking his head for those of you that can't see him. But I mean, we'll go with it. And I'd just like to start by asking how you both got involved in cancer research. And I'm going to come to the newly appointed Professor Phil. Kudos, Phil. But yeah, how did you get involved?
Well, I started from a clinical perspective. So I started as a medical senior house officer doing post-take ward rounds and seeing people come in as emergency cases. And the people with lung cancer were coming in with advanced disease. There was a shrug of the shoulders. We can't do much for them. Their life expectancy was days, weeks. And the messaging from senior doctors to junior doctors was, this has been always the case. It's been like this for decades, and there's nothing we can do about it. And so then that represents a challenge, and a challenge that I decided to try and address. So that was the journey for me. I don't know about whether that's different from you.
Yeah, well, similar, I guess. I was a junior doctor in training to become an obstetrician gynecologist, and it was around about the time that scientists had realised that there was this very strong link between a virus and a cancer, and in my case it was human papillomavirus and cervical cancer. And I was fascinated by whether that represented any opportunities for early detection and prevention through vaccination. So this amazing opportunity came up to come and do a PhD here in Manchester with Professor Henry Kitchener and Peter Stern, looking at HPV vaccination. And I just grasped it with both hands.
Oh, I love it. And is this how you guys met?
No.
Actually, we were medical school together. We both went to University of Edinburgh Medical School. But I think when we first met, we...
Again, for the listeners, Phil's shaking head.
I think, well, we were as medical students together in the same tutorial group, and I think Phil thought I was a bit square, asking lots of questions at 4:00 on a Friday afternoon, and he wanted to get off and go and play rugby with his friends. So we didn't initially connect, but then when we became junior doctors together, we saw that we did actually get on quite well. He's utterly appalled that I'm telling these stories.
It's great. We love it. We love that little insight. Phil doesn't love it so much, but there you go.
No
you agree to come on these things. Your life is open. So is it a coincidence you both ended up in prevention and early detection?
I mean, yeah, I think probably. So I'm a gynae cancer surgeon, which essentially means that for me, the best outcomes for my patients is when we get the disease really early. And so looking at ways of preventing it from happening in the first place and detecting it at its earliest treatable stage is an obvious way to improve outcomes for my patients. And I guess quite similar for you.
Yeah, for me, as a chest physician, you're involved in the sort of diagnosis and management of patients, not the oncological side in terms of chemotherapy. And the biggest impact I could have was on moving the diagnosis forward. And that was the area that I wanted to focus on to try and make the biggest difference.
Okay, and I'd like to pick up on that. So, I mean, would you be able to focus on this specific part of cancer prevention and early detection that you work in, Phil?
Yeah, so, I mean, I had an opportunity to work at Wythenshawe Hospital to do cancer research. And at that time, there really wasn't any funding, any focus on lung cancer really as a disease at all because of its association with smoking. There was a sort of a blame culture. It's the individual's fault. All they have to do is give up. And that sort of fatalism had, in a way, had gone through the whole of the sort of cancer community to mean that there wasn't any money or funding to try and make things better. But over the last few years, that has dramatically changed. And I had that opportunity to get involved in an area where I thought actually that would make a big difference. And therefore was able to complete a PhD in Manchester, which then gave me opportunities further down the line to have more, have a role in cancer research and an increasing role in the sort of setting of screening and early detection.
And I'm wondering, like, the emphasis is on early detection. And for my sake and for the listeners, would you be able to detail the importance of lung cancer early detection?
Yes, it's very straightforward. I mean, if you think of your lungs, they are 2 litres in size each. A lung cancer in its earliest stage, maybe the size of a marble, isn't going to cause any symptoms. There's a lot of area where it can grow, therefore, really patients, by the time they develop symptoms, it's too late. The cancer has spread, they're presenting with symptoms because it has spread somewhere else, say the bones or the liver, and then it's an incurable disease. However, if you can detect a lung cancer early, it's curable. So if you identify, say, a 1 centimetre lung cancer, and if you have an operation, you have a 90% chance of cure. Whereas the current state of play, because we're, waiting for people to come to us with their symptoms, half of people, die within a few months at the moment. So you're completely shifting a disease through early detection from one that is often palliative to one that is completely curable. So that intervention is really the only one that has such a dramatic impact. You need to find the disease early to cure it.
I'm very aware of kind of the landscape that you're working in and the work that you're doing, but I mean, for the listeners, would you be able to explain the incentives that you're driving at the minute for detecting lung cancer early in certain deprived communities?
Yeah, so the other thing with lung cancer is it's the close link with smoking, and smoking is the main drive of the development of cancer, lung cancer, and in the UK, smoking is also much more prevalent in more deprived communities. So if you look at the distribution of lung cancer, the burden of lung cancer across society, there is a marked difference depending on where you live, whether your community is affluent, whether your community is more deprived. And in our more deprived communities, there is a huge amount more lung cancer. And that's especially the case in Manchester, where we have some of the highest rates of lung cancer in the country. So the impact locally is huge. And that's really the impetus to try and do something about it from our own local community. So that association between smoking and deprivation is why you have the link between smoking and lung cancer. But you also have a link, deprivation itself, the air pollution, occupational exposures. There's a sort of a perfect storm of factors that come together to mean lung cancer has a massively higher burden in more deprived areas. And therefore, any intervention you give, if you really want to make a difference, you have to be delivering that to the people who are affected most.
How are you delivering it, Phil?
So in 2014-15, Matt Millen came to Manchester and said, we want to do something, we want to make an impact on lung cancer. And so we sat around a table, number of experts, patients, etc., around the table, thinking about what is it, how do we make that difference? And then the concept, the design of the lung health check then was born and taken from scribbles on the back of envelopes in a committee meeting to actually design a service where you implemented a screening service within deprived areas of Manchester. And the sort of design aspects of that were, well, we don't want people having to come to us. We want to take a service out to people so they're not having to worry about travel or parking, or they don't have to come to hospital. We want to take we want to make our service accessible to everybody, and especially to those who are in utmost risk. And the intervention that actually saves lives for lung cancer is low-dose CT scanning. So that's if you put someone at risk on a scanner, you've got a chance of detecting lung cancer and saving lives. And therefore you have to that's the intervention that you need. And so you take that out to people and make it convenient, make it accessible. And that's what the lung health check approach is. The other side of it, of course, is you're not calling it lung cancer screening, you're calling it a lung health check to reduce any sort of perceived anxieties associated with lung cancer. So if you live in a community where there's a lot of lung cancer, almost everybody you will know who was diagnosed with lung cancer has died of it. Therefore, the fatalism around that is also something you have to try and address. And hopefully, as we do more and more screening, we can then inform people and say, no, actually, this is a curable disease. We can do something about it.
Yeah, I mean, it sounds great, and I think it's kind of detracting from the ignorance is bliss perspective that I think a lot of people may take with screening and things. And I mean, just to reiterate, so you're addressing the challenge of socio-economically deprived communities that have high prevalence of kind of later stage diagnosis, and what you did was put kind of vans in car parks in deprived areas, and then people would come for this lung health check, and you'd kind of do routine follow-ups if there was any progression or kind of a later stage or early stage cancer. Is that right?
So, well, what you're doing in the lung health check is it's actually a bit more holistic than purely lung cancer screening. So the other things that we tagged onto it to make it more like a lung health check were things like a breathing test to look for COPD, which you get with smoking. We have smoking cessation practitioners on the truck for prevention of not just cancer but diseases associated with smoking. As well as an assessment of lung cancer risk. And then those individuals who are high risk there's a CT scanner immediately next door to where that lung health check takes place, and you go on and you have your scan, and the whole thing takes 20 minutes. So that part of the service it's literally about 20 minutes. It's very quick for people, very convenient. And then the data, the information that's collected is then brought into the hospital where it's looked at by specialists. And then those CT scans are read by specialists, and if you have a lung cancer, then you're immediately brought into hospital to have tests and diagnostics done. If you don't have lung cancer or a concerning finding, then that's the person's informed, and then further scans are arranged. So that's the sort of setup.
Great stuff. And I mean, my next question would be, what's the success been of this so far?
So, well, you can judge that in a couple of ways. One is in terms of lung cancer. So we've had a pilot about 5 years ago now where 1 in 23 people who stood on that truck and had a scan were diagnosed with lung cancer. 80% of those had early stage curable disease. 9 out of 10 were offered curative treatment. And that's because they had stage 1, stage 2 disease, whereas normally people are coming to us with stage 3, stage 4 incurable disease. So just standing on a truck means that you completely change the stage of presentation of lung cancer. You change it from a terminal disease to a curable disease simply by standing on a truck in a car park. So that was a profound thing to see. And as a clinician, sat in a clinic with a patient opposite me, I remember it distinctly, looking at somebody and going through the questions you do for assessment, but thinking in my mind, if you hadn't stood on that truck, then we may have been seeing you 1 year later or 2 years later and having a very different conversation. So it has a profound impact on you. In terms of the other things, offering people smoking cessation, early detection of COPD, etc., they also come in with the service as well. So Manchester really drove this. Was the innovation, the implementation of the lung health check started in Manchester, and then from that it's been adopted nationally through NHS England. NHS England backed it and said, right, we like this, we want to do more of it, and have funded a targeted lung health check programme. Initially at about 10 sites, but now there's 29 sites or so, and indeed the UK National Screening Committee is deciding whether to roll it out nationally. So the impact from what we started here in Manchester could have a profound impact across the country, and indeed beyond.
And fingers crossed for that funding. I mean, it's great to hear about this work focused on cancer outcomes in underserved communities, because I think that's kind of a large area of poor health, and it's great to hear that you're directly addressing in lung cancer specifically. And I mean, Emma, I'd like to come on to you and some of the amazing work you've been doing on HPV. I'm wondering if you'd be able to talk about this specific part of cancer prevention and early detection around HPV and cervical precancer.
Yes, so we now know that cervical cancer is caused by persistent infection with high-risk human papillomavirus, or HPV. And this is really exciting, this understanding, because it enables us to both prevent HPV-associated cervical cancer by vaccination. So that is by vaccinating our teenage boys and girls with the HPV vaccine, which then prevents them from ever getting infected with the virus in the first place, and so effectively prevents them from developing cervical cancer in the future. But also, because of this strong link, and because it is so intimately associated with cervical cancer, we know that it is a really good biomarker for screening. And what we mean by that is that we find evidence of that virus before the patient goes on to develop cancer. So we see it just as an asymptomatic infection, we see it in people who've got cervical precancer, and we see it in people with cervical cancer. And the importance of that is that it's actually quite a long period between becoming infected and developing a cervical cancer. And if you can screen that person for HPV during those years of infection, you have the opportunity to find precancer cells, which you can then treat, and again, effectively prevent the person from ever developing cancer. So it's understanding the biology underpinning this link between HPV and cervical cancer that's so exciting, because it does offer the opportunity to completely change outcomes with respect to cervical cancer. So in countries where they don't have organised screening programs and immunisation programs aren't universally funded, they have a huge burden of cervical cancer, often affecting young women, women in their 30s, 40s and 50s. And it's really a terrible disease when it's picked up in its later stages, with often terrible numbers of deaths and illness from the cancer. So, we're in a fantastic place here in the UK to be able to screen and prevent cervical cancer through understanding about HPV and the link.
Okay, and I know you've been working on alternate screening methods, and I'm wondering if you'd be able to tell the listeners a little bit more about that.
Yeah, so as you know, cervical screening has traditionally been carried out by a woman going to see her nurse in the general practice and having a speculum examination and having a sample taken directly from the cervix. And in the past, that was then looked at under the microscope to look for cervical precancer cells. But now we've moved to testing that sample first for high-risk HPV, and only if it's positive do we then look at it under the microscope to see that the person is genuinely at risk of cervical precancer. And because we know that this HPV is so intimately associated with cervical cancer, and also that skin cells are shed naturally during just normal life, the cervix sheds its cells and they contain HPV in them, that you might be able to actually use a slightly less invasive method of picking up HPV from the lower genital tract. So initially there's been a lot of work looking at vaginal self-sampling, which is where the woman collects a vaginal sample using a swab in the privacy of her own home, which she then sends to the laboratory for testing for HPV. But here in Manchester, we've been interested in looking at whether urine could do the same. In other words, whether we could test a urine sample for high-risk HPV, and if that would be as accurate as collecting a cervical sample and testing it for HPV. And so some work that we've been doing here in Manchester is looking at patients who we know to have an HPV infection when they come to the hospital to look for cervical precancer, and taking matched samples from the cervix alongside a urine sample, and just comparing the accuracy with which those two sample types detect HPV in those who've got cervical precancer. And so far the results are really, really exciting, to the extent that we think that a urine sample is not inferior to a clinician-obtained cervical sample for the detection of HPV. And the reason why that's so exciting is because, of course, women don't really like having a speculum examination and having a routine cervical sample. The evidence would suggest they're not really that keen on taking a vaginal self-sample either, but women are very used to collecting urine samples for all kinds of reasons, and we think that this might be a much more acceptable way of collecting a sample to find out if somebody is at risk of cervical precancer.
I mean, it's amazing, again, because it's that accessibility angle that both you and Phil are pioneering here. And I mean, I want to ask again, in terms of socioeconomically deprived communities, do we see less take-up of screening specifically in those communities?
Yeah, absolutely we do. So on the one hand, people from socioeconomically deprived communities are at greater risk of cervical cancer because they are often smokers, but also because they are less likely to go for cervical screening. So as we spoke about before, there is a long time period between becoming infected with HPV and developing cervical cancer. And so if you are a person that goes routinely for cervical screening, then there are many opportunities to pick up that infection and those cervical precancer cells prior to the development of cervical cancer. But if a person doesn't go for cervical screening, then those precancerous changes are not identified and they are not treated, which means that they are at risk of developing cervical cancer. So it's both the fact that they are often smokers, but also the fact that they are less likely to go for screening that puts people from socioeconomically deprived communities at increased risk of cervical cancer.
Okay, and I'd like to come on to that kind of two-pronged approach in a bit. But I mean, can I just clarify then that the challenge you're trying to solve in cervical cancer early detection is kind of the same as Phil. So it's detecting early where outcomes and prognoses are improved.
Absolutely, that's right. And specifically trying to address the barriers that we think are really important for marginalised groups that don't traditionally attend screening.
Okay, fab. I mean, a question for both of you again, and it's what encouraged you both to focus on cancers in deprived communities? Was it kind of one of those things that it was just so happened that the cancers that you were focusing on did have that angle, or was it specifically, I know, Phil, you've spoken about this before, but like, was it specifically, I want to help in terms of health disparities, addressing health disparities?
I suppose both. I mean, for lung cancer, the connection is so stark that if you don't make the big impact that you need to do. But they go hand in hand. And so I suppose both from a clinical service perspective, you have to make sure your service delivers to people who need it most. But also from a research perspective, you have to make sure your research is actually, the results that you get from your research are generalizable to the people who also get lung cancer. So one of the factors that we're trying to do in Manchester is also take our research out into communities as well, because the barriers that exist for services and accessing screening are the same barriers, and probably worse actually for research. So if you have a research study that looks at, say, lung cancer screening, and the majority of people taking part are not really representative of the people who get lung cancer in your community, then that means the results are not necessarily as generalizable. So the push more recently has been to try and break down the barriers to research participation as well, because that's really important, because the results we get, we want it to be generalizable to people more broadly.
Yeah, and for cervical screening, we know that people who are from more affluent areas are much more likely to go for routine screening. They're much more likely to have been immunised as pre-teens, and therefore you have this situation whereby the worried well, who are those people who go for screening and vaccination programmes, are doing extremely well from the services that are available here on the NHS, but those that have poorer access to those services just get a really bad deal in terms of much more likely to be diagnosed with cancer, much more likely to have bad outcomes. And so it is addressing that health disparity and trying to make it much more even for the whole population so that everybody can have good outcomes.
There's a lot of overlap between both of your research areas in terms of prevention and early detection of cancer, and you both have this focus on addressing needs in underserved communities. It makes me want to ask, and I kind of know what the answer is going to be, but I mean, does the fact that you both work in the same environment make it easier for you to collaborate on projects?
Yeah, I would think so.
Is this dinner time talk?
Yes, of course.
Yes.
Absolutely.
So, I mean, that is something that we probably go on to talk about just now. But yes, I mean, noticing that the cancers that we're interested in do seem to affect a similar population demographic is clearly of interest to us, because it was like, well, if you're tackling these disparities using your lung health check in socioeconomically deprived communities, is there a way that we could also harness that fantastic service to try and take cervical screening to the same community? So that was really a tea time discussion, I think, yes.
Love it. Your dinners must be amazing. Solving world health issues, blimey. We just get on to the why have we got boiled potatoes and not roasted? Do you know what I mean? But anyway, you've led me on, Emma. So, are there any projects you're both jointly working on?
Funny you should ask that.
Funny I should ask that.
Yeah.
As if I know.
So yes, no, we've started an initiative called the MOPED Initiative, which is the Mobile Cancer Prevention and Early Detection Initiative, which is essentially, as Phil says, taking cancer research to the communities that need it most. And in the case of lung cancer and cervical cancer, that is communities from socioeconomically deprived backgrounds. And so because of the success of the lung health check, whereby people from those backgrounds are actually attending for lung health checks and lung cancer screening, we decided that that might be a really great opportunity to also look at whether we could offer our new urine HPV test to people attending that lung health check. So in other words, could we do a so-called one-stop screening shop for both lung cancer and cervical cancer? And so that is a research initiative that we are very excited has just got started. And it is using a kind of a research room at the back of the lung health check, which is the clinical service.
So is this just in Manchester at the minute?
Yes, it is.
Okay, paint me a picture. What is going on inside these trucks? We've got a CT scan for Phil's stuff.
Yep.
What else have we got? How many people are in there?
Well, it's quite it's quite an industry, but it all fits together with the logic of essentially trying to address things in a one-stop shop model that are, if we're sort of saying that we have underserved communities that aren't accessing services or getting the health benefits from the NHS or whatever, then trying to address that and doing so in a way that's acceptable. So we don't want to overburden people, but actually the feedback has been fantastic actually from everyone attending the truck. When you go on the truck, the atmosphere is great, and people do appreciate just having these various things checked. So you see, there's a flow to the truck where you see your lung health check nurse who describes what's going to happen. There's a room where you go, if you're a smoker, you go and see the smoking cessation practitioner. Then the research team is next, and it's not viewed as, and I think this is great credit to the clinical service actually. Research is not viewed as an added extra. This is fully integrated within the flow of the truck. That you're going around these rooms, and obviously you don't have to go in each room, but these rooms are there. There's a flow, and then you have your scan at the end, and off you go. You can do your shopping if you wish to, or go home. So the whole thing is very well integrated. It's a great atmosphere, and the feedback we're getting is really good. But what we're trying to do is deliver all these potential health benefits to people in a convenient way, and why not try look for other malignancies in the same way that we're trying to look, say, for COPD, or indeed trying to help people with the smoking. So it's all part of that same package.
Where did you find your TARDISes?
There's two big trucks with the lung health check team in them, and also a mobile CT scanner. So it is a big setup, and the logistics of it are significant, but it's certainly worth it.
So Emma, where do you come into this kind of flow?
So in the research room, obviously I'm really only interested in targeting people with a cervix, mostly women, and we are asking those women when they are, if they're interested in taking part in research, whether or not they have routinely been for cervical screening in the past, and if they might be interested in having a cervical screening sample taken in the form of a urine test. And we are targeting women over the age of 65 who have exited the cervical screening programme. So we're not interfering with the NHS cervical screening programme. So this is really trying to identify those who haven't attended NHS cervical screening. And that's mostly because cervical cancer actually has the poorest outcomes in terms of contracting the disease and dying from the disease for women in their 70s. And currently we stop screening at 65. But if people haven't been screened, as I said before, then they haven't had a cervical precancer treated, which means that they are at risk. And so it's trying to find out whether those women who haven't been for routine screening, perhaps because they didn't want to have a speculum examination, might might be interested instead in giving us a urine sample. It's just a very small urine sample collected using a little device called the Crosbie, which reliably collects the first fraction of urine that a woman passes, and then sending that to the laboratory to be tested for HPV in the same way. So taking part in our study is actually quite a short thing, but we're hoping to get lots and lots of patients agree to take part so that we can see whether or not this could be a successful initiative to be rolled out.
And I'd just like to emphasise to the listeners, this is in car parks.
It is,
Yes.
You'd never have thought it. Both of you, what's your hopes for the future of this incentive? Rolled out nationally? I'll prompt you there.
Yeah, so I think for me, it's kind of reappraising that age at which we stop screening. So other countries, for example, Australia, Denmark, some of the other Scandinavian countries, they actually stop screening for cervical cancer at 79. But here, perhaps for historical reasons, and perhaps because the test is uncomfortable in a postmenopausal woman, we stop at 65. So it's really sort of examining that and with fresh eyes and saying, should we be stopping at 65? Is there something we can do for women who are older than 65? And, could urine be a reasonable alternative? Do women who haven't been screened before, particularly those from socioeconomically deprived communities, do they prefer to collect a urine sample for cervical screening? And is a one-stop screening shop something that they'd be interested in?
And I mean, are you kind of looking to integrate, I mean, it's already a TARDIS as it is, but I mean, it seems never ending. So are you looking to integrate other cancers into this one-stop screening shop? Get copyright on that, by the way.
So, I mean, it's about targeting your screening to the right people. So, obviously breast cancer screening it tends to be in a slightly, it occurs in a different way. You need mammography, you need ultrasound services, you need biopsy services, and so on and so forth. And, that's not really the same demographic of individuals that are at greatest risk of lung and cervical cancer. So it's about being smart about what screening bundle you offer. But there certainly are other cancers that are things that we should be considering if this is successful.
Which I'm sure it will be. I have all the hope. And a personal question again, but I mean, you're both cancer researchers and you both have kind of many hats that you wear. How does it feel that you're in a fast-paced environment? How do you deal? I mean, you've both got 3 kids and a dog and 2 cats. Sorry, you all missed this preamble, but it's the bits that I love. How do you balance it all? How do you find it? Do you kind of feel like you're going to break down into a heap at some point? Or, I mean, Phil, you're very slow, not slow. You're very steady. Trying to think of the word.
I think it's the same for any family, isn't it? You've always got time pressures, too much to do, and you just have to do the best you can each day and every day. And actually it helps in a way to be in the same in sort of research environment, because the conversation we have are very, we have a debrief where we maybe walk the dog or whatever, having a chat about the day's events. And then that just that is put to bed, and then we deal with the day-to-day with the kids and what's needed. I don't think it's any different to any other busy family, is it, particularly?
No, I don't think so. But we are both very driven. And I think if we weren't so passionate about what we did, perhaps we wouldn't manage to balance it. But it's that drive to really make a difference for our patients that's kind of fueling this fast-moving, exciting time in our lives.
Yeah. That dog must get overwalked if you're discussing debriefs from the day. Jeez, I really feel for him. His legs will be falling off by the end of it. And I mean, it's another personal one, but how does it feel to know that you're both benefiting the lives of cancer patients, and also kind of cancer patients that are from these economically and socioeconomically deprived communities?
I mean, to deliver research that has an impact it's a fantastic area to work in. It's motivating. I suppose you're never satisfied that what you've done is good enough, and you always are looking for ways to keep making innovations and improvements. But when you do pause and think, actually, yes, it has had impact, that is a really good feeling. But no, you never sort of pat yourself on the back particularly and go, great, job's done. You're then moving on to the next thing to go, well, how do we get it better? Or, I mean, you're constantly looking for ways to improve what you're doing. That's my angle anyway.
Yeah, I mean, just totally driven by the desire to make a difference for our patients, and constantly striving to tackle the next hurdle that we see. So it's not a journey that has ended or feels like it's ending anytime soon. It feels like a long, winding road that we are enjoying the journey of. But yeah, lots more challenges ahead, I think.
Yes, I mean, there's so much more to come from you both. I am so sure. We'll have you here in another month talking about something different. Have you got any tidbits, any secrets, anything in the pipeline we can be looking forward to? Emma's got a cheeky look on her face.
Well, we are looking at the urine test in all kinds of different scenarios. So looking at different groups of people who may not have been for routine screening in the past. So that's exciting to see if there are ways of addressing more than just this socioeconomic deprivation issue, but perhaps we could appeal to other groups of people who perhaps haven't been screened before. So yeah, definitely watch this space.
Phil, in terms of your mopeds, what do you want to come out of that?
I think it's just for there to be an acknowledgement that research has to be representative of the people in our society, and we need to have because the results we generate, the data we generate, has to be of benefit to everyone and not just to a select few. And I think that's an important, whether it's by physically taking research into a car park or whether it's simply saying, actually, we need to try and be mindful of this issue and try and overcome it. And I'm sure there are various different ways of doing that, but it's just an important issue that we should be addressing. That's the key, I think, to it.
God, you've got the key and the secret. Hope everybody got that reference. Honestly, thank you so much, both of you, for speaking to me today. I know you've got absolutely hectic schedules, and it's so appreciated because we get to speak about all this amazing stuff. And yeah, you're the cancer research power couple, and there is no other term for you. Yeah, I might even have a picture of you on our wall at work as the gods. But yeah, I hope as well that, I'll be speaking to you in the near future about this work because it's incredible. And I think the pace that it's moving at and people seeing that it needs funding and things is incredible. But yeah, just thanks again, guys.
Well,
You're
thanks for
great.
having us.
Thank you for having us.
It's been fun.
Worries. It has been fun, hasn't it? And thanks again for the listeners. I'll link Phil and Emma's work in the blurb because there's a lot of stuff that we have written about because, again, power couples, they need their airtime. So thank you for listening to us, and see you next time. If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.